right, guys, here we are doing another Facebook Live. Tonight we're going to be talking about vertebral compression fractures. Vertebral compression fractures, that's a vertebral compression fracture behind me. Yes, I got a green screen, so now I can put cool images up. I'm getting nerdier and nerdier every time I do one, right? So anyway, yeah, my phone's on, my phone is on airplane mode because I don't want people calling me while we're trying to do this. So tonight we're going to talk about, I think the topic that we posted was broken bones of the back. And there's a lot of different quote unquote broken bones of the back. But tonight we're going to focus on something called vertebral compression fractures. And so real quickly, I'll cover some of the other broken bones of the back. Obviously, you can break your bone in a car accident. A 20-year-old with very strong bone, you know, at the peak of their bone strength, etc., would break their bone, and that would be due to the high energy delivered to their bone. Another example of a stress fracture, the same kind of stress fracture you might see people who get stress fractures in their feet from running or in their shins from running, things like that, can occur in the low back, and we'll talk about that sometime too. And that's when you get a fracture in a specific area called the pars interarticularis, again in young people, and occurs usually from repetitive trauma, cheerleaders, football players, gymnasts, people who hyperextend a lot. There's another fracture that sort of falls in a different category, if you will, sort of a stress fracture, sort of a fracture induced by trauma, and that is what we're going to talk about tonight, which is the vertebral compression fracture. It's misunderstood, it's very different than the other two fractures, and quite frankly, talking to you about vertebral compression fractures really has the potential to make a big difference for a lot of people. They're generally seen in older people, but they can occur in anyone who has very poor bone quality, someone who maybe is on a medication or being treated for something or has a disease that affects the quality of their bone. But generally speaking, as we get older, our bones start to lose their quality, their strength. And I don't want to just say calcium or something like that, because it's a lot more complicated than that. It is calcium. It's also vitamin D. It's also vitamin K. It's also exercise. But all these things sort of come together to reduce the strength of the bone. And you know, like we're seeing here, the trabecula, the spongy interior of this vertebral body, which is really made up of a lot of trabecular bone, which is more like a sponge, versus cortical bone, which is more like concrete. The cortical bone is what's on the edges. That sponge becomes thinner and thinner. The little trabecula in that sponge become thinner and thinner. And we're going to talk a lot more about that. But that's what happens as we get older, whether we like it or not. We can slow it down through diet, through exercise. So if you're a smoking, drinking, prednisone using couch potato who's 200 pounds overweight, then yes, your bone is going to go downhill a lot faster than someone who, say, is very active and has good nutrition and is on very few or no medications into their elder years, you know, 70s, 80s, 90s. And yes, it is possible for that. That is possible, believe it or not, to be very healthy. Read a book called The Blue Zones. We'll review that sometime. Anyway, don't want to get off topic, but yes, it is possible to keep your bones healthy. The big problem with vertebral compression fractures is they're very often underdiagnosed or misdiagnosed as, say, a back sprain or someone who's just got chronic back pain, who's complaining, etc. And they can occur from falling down some stairs or off of a few steps from a ladder, which should be pretty high energy trauma. But I've literally seen people with vertebral compression fractures from sneezing, as hard as that is to believe. But those are people who are extremely deconditioned. They have very poor bone quality. They're usually in their 90s, the ones that get a fracture from a sneeze. But I've seen it even younger as well. The history of vertebral compression fracture and the treatment of vertebral compression fractures is interesting. There's been a procedure called a vertebroplasty, which has been around for quite a while. But in more recent years, about the last 20 years, maybe a little bit more than that, this procedure that I'm going to show you tonight, and I've actually got, hang in there because I've got a video to show you of me doing one in the office, has been around since the 90s. And I actually trained on these and was involved in the evaluation of a product called Kyphon, which was originally its own company, was ultimately purchased or acquired by Medtronic. And now there's a lot of other companies that produce similar products to fix these bones. But Kyphon, which was an independent company at one point when I was first using it in Houston with one of the primary spine attendings, the doctors that teach the fellows, which I was a fellow. I was a spine fellow after my residency there. And I remember the rep's name was David Podlin. So I don't know if David Podlin will ever see this, but hey, David. So David was the rep at that time. This was, again, 20 years ago or more. So I wasn't even a spine fellow at that time. I was actually a resident. I was still in my residency training. So I've had a lot of experience with this. I've seen this for a long time, and I actually was using it before most doctors even knew that it existed, because we were doing the study at Baylor College of Medicine back in the 90s. It was originally in the early 90s by a guy named, I think, Mark Riley was the one that originally described kyphoplasty to be differentiated from vertebroplasty. But anyway, I've got a PowerPoint slide. I'll try to go through my PowerPoint slide deck here relatively quickly for you, so as not to bore you too much. But here we go. So percutaneous vertebral augmentation. And what does that mean? Boy, that's a bunch of words there, isn't it? Percutaneous just means that we are doing this through a very, very small incision. The incision for this, it's a truly minimally invasive procedure that is done through a fat needle, or some people would describe it as the tip of a lead pencil. It's very small. We're talking 2 millimeters or less. It's a stab incision. The incision is so small that there's nothing to close, that we literally just glue it shut and put a Band-Aid on. There's no point even putting a stitch in. The skin seals off and heals within a few, the blood that forms a scab seals the skin off within, honestly, probably half an hour or 2 hours, but it's a very small incision. You can't even really see the incision in a lot of cases. But that's what makes it percutaneous. Vertebral is because it's a vertebral body, okay? And augmentation means that we're changing the vertebral body. We're trying to increase the height. And real quickly, let me go over this. I talk about the 3 Ps when I talk about these procedures to my patients. I talk about pain, which is the one that usually brings them in or alerts their primary care doctor. And when I said this is missed, I don't mean they're always missed. Primary care doctors catch these all the time. ER doctors catch these all the time. But there's still a whole lot that go undiagnosed, maybe because the patient doesn't even think there's anything that seriously wrong and doesn't go to their doctor in a timely fashion. They just think they have a really, really bad sprain, or they threw their back out. But there's pain and there's posture, and that's why it's called a kyphoplasty, because when someone bends forward, like a little old lady bends forward, that's called kyphosis. In a kyphoplasty, plasty is you're changing it, you're fixing it, you're trying to undo that kyphosis. So one of the goals is to obviously treat the pain, but also to correct the curvature in the back. And the last P I use is paralysis. And that's because if these fractures are not diagnosed in a timely fashion, they can actually lead to paralysis. This is very uncommon, but there was a famous case floating around San Antonio. Yeah, I can say San Antonio. I'm not naming any doctors or anything. But anyway, the doctor didn't realize what was going on. And the patient kept complaining of pain and probably was getting very bent over. And ultimately, the bone became so flattened that bone shot backwards, or retropulsed is the medical word, into the spinal canal and paralyzed the patient. At that point, it was kind of too late. I mean, they could certainly have surgery to get the pressure off their spinal cord, but usually when it gets that severe, they're probably not going to get that function back, sadly. And that, again, is very rare, but it's possible. And so, the fact that this is done in the office, it was once done in the hospital. I started doing mine in the office in 2012. I think people thought I was crazy, and now we do them all in the office, and most people do. Now everybody's jumped on the bandwagon, of course, but I was one of the first ones to go into the office and do these in the office, and people are like, I can't believe you're doing surgery in your office. But the reality is I've done a couple thousand of these, probably more than that, levels. And certainly my practice, me and the other doctors who are in my practice collectively have done, I'm not even sure how many, but I personally have done over a couple thousand levels. And that's a lot for this particular procedure. And so, and again, I've been doing it for 20 years, arguably, since it was in the 80s, mid 80s, 98, something like that. Anyway. And so I'm very comfortable doing this. And yeah, you shouldn't do this in the office unless you're very comfortable. Another thing that I'll mention is, why do I think Spine Center of Texas is probably one of the best places to have your kyphoplasty? So let me do my sales pitch first, but this is actually, I think, important information. Four people, I guess, 4 different types of trained doctors can theoretically do these. Radiologists can do these. Anesthesiologists can do these. PM&R doctors can do this, and Dr. Forzani, who's in Spine Center of Texas with me, is a fellowship-trained, board-certified interventional pain doctor. He's physical medicine rehabilitation, and of course a spine surgeon. Classically, spine surgeons were the only ones that did these, but then after they became more popular and they were a great way to treat pain, other doctors jumped on the bandwagon. So what is the downside and the upside of each one? Well, if you go to a radiologist, radiologists don't see patients. So what typically happens with a radiologist is a patient will come through the ER, they will see that the patient has a fracture because they're the ones reading the x-rays, or they get the MRI and they see the patient has a fracture, and then they'll call downstairs or they'll call the primary care doctor or whatever, they'll grab the patient, they'll fix them, they'll do it right on the spot, which isn't necessarily a bad thing as long as they know what they're doing, and then they'll send them home. Well, radiologists don't see patients, they don't have a clinic. So if that patient has problems, radiologist is never going to see him again. If that patient has a complication, he's got to ship him off to a spine surgeon to dig the cement out of their canal. And I've had to dig the cement out of the spinal canal of a patient who had a kyphoplasty done by another doctor before. So that is a real risk. That patient had a real problem. I was able to fix it, but you know, I kind of was frustrated that it happened to begin with. With a pain doctor, they can treat their pain, they can do their procedure, and they'll see them afterwards. They'll make sure that, you know, when you have a surgery normally, if you have your appendix out or you have spine surgery, someone needs to see you afterwards. They need to look at your wound and make sure you're doing okay. Well, the pain doctors do that, the PM doctors do that, and the spine surgeons do that. So all those are equivalent. The only person who doesn't ever see the patient again, which blows my mind, is the radiologist. He never sees the patient. He leaves it to the primary care doctor or someone else to basically take care of his patient post-operatively, which to me is just not the best medicine, in my opinion. That's my opinion, so I'm sure some radiologist is going to be mad at me for saying that. In terms of a pain doctor or a PM&R doctor, if they have a problem, they have to turn to a spine surgeon, someone like me, to go in and dig the cement out of the canal. And so this is why spine surgeons typically do this, because if they had a complication, they had a mess, they could clean it up. So I think the thing that really makes Spine Center Texas unique is that, and then of course, if a spine surgeon who doesn't treat pain had a patient who continued to have pain, say they had facet pain or pain from somewhere else in their back, they wouldn't be able to take care of that patient. They would do a kyphoplasty. Oh, sorry, you're still having pain. Go see a pain doctor. In our practice, we've got a pain doctor and a spine surgeon under the same roof. So if you have a complication, say Dr. Sahni were to have a complication, which he has not because he was trained by me and he's amazing and very, very good at doing these, I would be able to take care of that patient. Knock on wood, it could happen. And if it happens, I will take care of it. If the patient continues to have pain, I do a lot of pain medicine myself, but also Dr. Sahni there is available also to help treat the patient with pain, especially medical management. I do a lot of interventional pain, injections and shots and kyphoplasties, things like that, and not as much medical pain management. And of course, that's Dr. Sahni's forte, his advantage over me. We both do the pain procedures, and of course I do, my advantage over him is the spine surgery. But we're all under the same roof. The patient has a problem, I can help from a surgical standpoint. The patient has a problem from a pain standpoint, Dr. Sahni can help. Whereas when you go to a radiologist, they say, treat them and street them. That's literally what they say. So they treat them and street them, which means they're not going to follow that patient up again. Not a good choice. And then as long as that pain doctor, whether they're a PM&R doctor or a spine doctor or a anesthesiologist, has a good relationship with a surgeon, can get you quickly to a surgeon if there's a problem, then I think that's also very reasonable. And of course, pain doctors can treat the pain. But again, be aware of who's doing the kyphoplasty on your mom or your dad, and what are their qualifications, and can they bail themselves out, especially if you're in a small town where you may not have access to a surgeon. It could be a real mess. I've had to bail people out. I've had to bail out pain doctors doing cervical epidural steroid injections where they had a bleed and the patient was quadriplegic within 2 hours of the injection, and I had to take them emergently to the OR. So these things do happen. But anyway, those are the different kind of doctors, and those are the reasons that you may or may not want to use a doctor. And I believe that our model is the best, especially when it comes to things like kyphoplasties or any surgery, because if my surgery doesn't fully treat their pain, Dr. Sahni is there to help me. If he needs a surgical person, then I'm there to help him, or he has a complication from a pain procedure that he does, I'm there to help him. We're all under the same roof, we're all collaborating, and I think it makes a big difference. So that's my spiel on who does these and who's the best person to do your procedure. So, all right, let's jump back to this talk, and I will try to go through these. So what is vertebral augmentation? It's a minimally invasive procedure. Like I said, it's the tip of a pencil where we go through something called the pedicle, and I'm going to show you some images of that here in a second. We enter through the pedicle, get into the broken bone, put in a balloon, try to take some of the kyphosis away. A lot of times we can't. The bone's just too weak. It just sort of like crumbles around the balloon. But sometimes we are able to get a correction and actually take some of the curvature out of the patient's back. I always tell them that's my primary goal is to lock their fracture in place. That's why it's good to get these early, because you don't want to lock it in place after it's collapsed a lot. You'd rather lock it in place before it collapses a lot. You are making a safe space. And the big difference to me, in my opinion, between vertebroplasty, which is just like this except there's no balloon, if you look at studies will show that the extravasation rate for vertebroplasty, and that means the cement shooting outside the bone, kind of going all over the place, could go to the spinal canal like I talked about. I had to dig cement out of someone's spinal canal one time. It can also go forward into the aorta and affect all kinds of areas. So in a vertebroplasty where you're not creating a cavity, a controlled cavity for the cement to go, it has an extravasation rate. In other words, it goes outside the vertebral body 70% of the time. Yes, you heard me, 70% of the time. Now, obviously in most cases that's not a big deal. Otherwise those procedures would be outlawed. Usually it ends up not being a big deal. A little bit goes out, they stop before it gets to be too much, or in some cases they have to go see a spine surgeon to dig the cement out of their canal. And with kyphoplasty, it's around 7%. And I would say my number is probably lower than that, but I'm not 100% sure. But it's a very low number. And out of the couple of thousand levels that I've done, I haven't had a single person that's had to have anything done because of extravasation. In other words, my extravasation hasn't taken someone to the OR or required them to have some other intervention to correct essentially what I messed up. So it was not clinically significant is the term. When you have to have your back opened up to have cement taken out, that's clinically significant. So here you can see the needle's going into the bone. The balloon is insufflating, correcting the fracture, and creating a space for the cement. And then in number 6 there, it's filling. And here you can see it again. Balloon there on the left. The balloon then deflates. It's just inflated with a liquid. A liquid that's radio opaque, so you can see it on the X-ray, but it still contains that fluid. Occasionally a balloon will pop. I haven't had one pop in a while. It's not a big deal if they do, but you prefer for them to have created the space before they pop. But most of the time, they very easily come out. Haven't had one pop in years, actually. Once you take the balloon out, you then put the cement into that cavity. The cement hardens. It's called polymethyl methacrylate. It's been used actually first by dentists and then by joint surgeons for doing total hips and total knees. And it's been around for a long time. So it's well accepted. The body doesn't react to it. It's very effective. And so, and it becomes hardened within minutes. And so the patient's fracture literally is rock hard within minutes of doing the procedure. And so now their bone was moving, it was shifting with every breath. Every time they breathe, they'd have severe pain. The fracture is corrected in many cases, locked into position. It's like an internal cast. And now the patient no longer has pain. So literally I had a 96-year-old one time come in for a kyphoplasty, and she literally came in a wheelchair and walked out of my office within an hour of having the procedure on her feet, walked out with no pain. One of my best stories. I mean, we always tell our best stories, right? But it was absolutely amazing. 96 years old. So let's proceed here. What is a vertebral compression fracture? I'm going to try to go through this relatively quickly. Let's see what's important on this slide. It's compressed, weakened bone, causes severe pain. It's usually caused by osteoporosis, but someone who has normal bone could have a compression fracture if they were in a high-energy car accident. Tumors are another one. I've seen a number of tumors. That's why we sometimes take biopsies and send them off for pathology. And like I just said, traumatic injury. They generally occur in the thoracic and lumbar spine. That's where we see them most. We don't really see them in the neck. And vertebral compression fracture pain is movement related, like I said, even with breathing. And I've literally seen people get these fractures just from sneezing, as crazy as that sounds. So here's what osteoporosis looks like inside that box, if you will. And let me just cover that real quick. Let me grab my little model here. So what's breaking here? So I'm going to show you this picture, but if you look here, this is a vertebral body. These are the discs in between, and we've discussed that before. There's the spinal canal in the back. The vertebral body is almost like a box. And the few millimeters of its outer shell are cortical bone, which is more like concrete. And the inside is spongy bone or trabecular bone, okay? And that's what I'm getting ready to show you here. And so there on the left, normal bone has very thick trabecula. See how the trabecula are nice and thick and strong? They're strong in compression. They're strong in shear loading. They're even strong in tension. They have a good modulus of elasticity. And when you're young, your bones are pretty darn strong. Unless you're in a really high energy accident, it's pretty tough to break a vertebral body, although it happens. We see young people in car accidents with them all the time. On the right side, as we get older, as we don't exercise as much, our body, the cells that make bone called osteocytes start to age as well, and they can't do as good of a job. The thickness and the robustness of that trabecular bone decreases, and you can see there's more air, okay? Look for bone, look for air. You can see on the picture on the right, there's a lot more air, if you will, and not as much bone. That bone becomes thinner, and so a sneeze or falling on your butt from standing can cause that vertebral compression fracture. And the other thing that's very interesting about vertebral compression fractures is they can break and they can heal. So you could get one, your vertebral body collapses a little bit, and then it heals, and you feel better. Your pain goes away. You still have the kyphosis. You're thrown forward because they tend to throw you forward, and that's what's called a kyphotic deformity. And then down the road, maybe a few months later, or even just a week later, you break it again. The pain comes back and it heals. So they can literally break and heal, break and heal, break and heal. And some people, before MRI was real available, would literally just follow them on x-ray, on plain x-ray, and watch the kyphosis form, watch the angle get worse and worse every time the bone collapses. So it literally is collapsing almost on a daily basis or at intervals, unlike, say, a broken wrist. You fall, you break your wrist, you either get it fixed or put it in a cast. You fall, you break your hip, you get some metal put in it. It's sort of an acute thing. This is more of a chronic, if you will, acute on chronic. It breaks, it heals, it breaks again. And that's what happens with these osteoporotic fractures. Again, look here in the normal bone, abundant trabeculae, moderate osteoporosis. In other words, there's loss of that spongy bone or trabecular bone. And then, of course, we start to get the compression fracture. The end plates give up. There's just not enough strength in between the end plates anymore, and they collapse. 50% of women and 25% of men will have an osteoporotic fracture in their lifetime. 10 million Americans have osteoporosis. 34 million have the step before osteoporosis. We can go over that that definition of osteopenia, or normal osteopenia, then osteoporosis. But basically, osteopenia is the bridge between normal and osteoporosis. It's actually a mathematical thing based on bell curves, Gaussian curves, standard deviations. 700,000 osteoporotic fractures occur annually in the United States. So these can be fixed. Classically, it was in the operating room. But the cost was so high in the operating room, and risk of infection is much higher in a hospital just because there's so many sick people there and so many bugs there potentially. And so now a lot of people have them done in the office, and I do them pretty much exclusively in my office. I did them for years in the hospital. The other really interesting thing is in the hospital, the patient was generally put under anesthetic, so they were completely out. So they get intubated, they'd be lying on the table. And I actually saw more than one case, not a lot, but more than one case where, because the patient was unconscious, when they were being moved from the operating table to have the procedure or off after the procedure, in both cases they were unconscious, they ended up with another fracture. I'd fix their back, they'd wake up and say, wow, I hurt just as bad or maybe worse, and it seems to be higher or lower. I'd get some x-rays or an MRI, and voila, we actually had fractured the bone, probably moved, who knows exactly what had happened, but it would make sense because when you're asleep, you can't say, ow, that hurts. When you have it done in the office, the way I do it in the office, they're always awake. They're under something called conscious sedation, but I'm able to speak to them because they are their own neuromonitoring. If I'm putting my needle in a funny place or I'm hurting them, they can speak up. They can actually talk to me during the procedure. They may not remember it, but they can talk to me. They're sort of in a twilight state while they're having the procedure done. And I have never now, I've been doing this in my office for 6 years, and we've done hundreds, way more than that. We have never had anyone get an adjacent level fracture being moved on or off the table because they're awake, they're moving themselves, or we're moving them under the table, and they can say, oh, that's hurting me, and we can be careful. Sometimes in the OR, one person's twisting one way and one person's twisting the other, and you end up with a problem. So what are the alternatives? You can do bed rest, but this leads to the downward spiral. We learned a long time ago that laying in bed is just not good for anything, whether it's an ankle fracture, a hip fracture, or a broken bone in your back. Laying in bed leads to a lot of problems. Physical therapy, if it's healing well and the pain's better, physical therapy can be done. Bracing, it used to be that Medicare required us to brace these patients for a number of weeks before we could even consider a kyphoplasty, but what we found is sometimes even in the brace, their fracture would progress. And because this thing in most cases is so amazing, the patient's pain is gone, they're up and walking. Like I said, my 96-year-old walked out of my office within an hour, that there's just no point in waiting. We don't want to let them progress to the point where they have poor posture from kyphosis or paralysis if the bone pushes back into their canal. And now that we're doing it in the office, it saved Medicare a ton of money because it's astronomically cheaper in the office than it is in the hospital. So it's a win-win for everybody. And then, of course, open surgery if the fracture was collapsed enough before kyphoplasty was available. And still in some cases open surgery is required, but most of the time it's not. They literally have to have their back opened up and have screws and rods put in their back to stabilize their back. And of course, tolerating the pain through medications or what other, possibly I guess a dorsal column stimulator. Those are other alternatives to the kyphoplasty. But the kyphoplasty is so successful that there's just a lot of, that's mostly what people do now who are in the field of treating people's spines. The benefits are significant pain relief, increased range of motion. Oh, and I didn't go over this. This spiral, this downward spiral, this is true with hip fractures too, by the way. We know that people who get hip fractures, if they don't get up and get moving, have a very high mortality rate. But you have back pain, spinal deformity, that kyphosis, decreased lung capacity, because if you're bent over, you can't breathe as deeply. So you have impaired function, loss of appetite because your abdomen's being compressed, and now you're not as hungry because it doesn't feel as good to eat anymore. Decreased activity, more bone loss, increased fracture risk, increased comorbidities like blood clots and pneumonia, and then, of course, increased mortality. So laying in bed with a broken bone is not a good thing. The benefits are pain relief, range of motion, return to activity, improved quality of life. It's an outpatient procedure, so there's no overnight stay. We do it right in the office. People are in and out of there in an hour or two. Increased mobility to reduce the possibility of blood clots, pulmonary compromise such as pneumonia, decubitus ulcers, and even urinary tract infections aren't listed here. And of course, there's no general anesthesia. We don't do general anesthesia. We use propofol, the same medication. Sometimes we'll use something a little stronger than that, but it's about the same type of medication that a person would get for a colonoscopy. And the medicine's on and off in just a few minutes. We can put it on, do the procedure. Procedure might take 15 to 30 minutes, and then once we stop giving the medication, it wears off in literally just a few minutes. That's what I mean by on and off in just a few minutes. So an estimated Americans with osteoporosis, 10 million. Estimated compression fractures annually. This is in the back, 750,000. Number of them that are painful. So not all of them are painful. In fact, less than half are painful. And then a vertebral compression fracture takes place every 45 seconds. As long as the patient's not collapsing and it's healing and they can tolerate a brace or they appear to be healing, they don't have to have one of these. Pain is usually the biggest reason we do it. The way to evaluate this is with x-ray, of course, and I oftentimes, if they didn't have pain a week ago, they sneezed or fell or whatever had their mechanism, and now they, it is hard to hear me. I don't know why that is. Let's see. Let me turn up my mic. Testing, testing. So the person that just texted me and told me that it was hard to hear me, is it easier to hear me now or not? Make sure my... Hang on. Is it easier to hear me now? I guess he'll send me a text. The person will send me a text, hopefully. I'm sorry if it's hard to hear me, guys. I thought I had everything tweaked out here properly. Here, I'll hold the mic right up to my mouth, and maybe that will solve a problem. So x-rays can be used, and if you know whether the patient didn't have pain, they fell, now they have pain, I get an x-ray, it shows collapse of a vertebral body, then, of course, I know that compression fracture happened in the last week. MRI is probably one of the, yes, you can hear me better now? Okay, good. MRI is one of the best ways to evaluate these. Some people can't get an MRI. Okay, turning up the mic worked. All right, the mic is turned up. Sorry, I'll talk louder. Yeah, I got the mic turned way up. People who can't have MRIs because they have a pacemaker or a spinal stimulator or a bladder stimulator or whatever type of device that precludes them from having an MRI can have a bone scan, and of course a CT scan. It can also be used in complex cases. If you can't hear me, person who let me know, please let me know. Again, I want to make sure that everyone can hear it. I'm sorry about that. Let me see if this helps. Okay, yeah, there we go. So hopefully you can hear me. Keep going here. Okay, so here's an MRI and here's an x-ray. So on the left side, there's an MRI, and that's the kyphosis that I'm talking about. When the bone breaks, the back folds forward. You can see, if you're looking at this image on the left, I'm sorry I can't really point at it with something, but the front of the person is, well, you know what? Let me ask you this. I can use the mic in my computer, and that might work better. Let's try that. Hang on. I can fix things real quick. Let's use the iMac microphone. Testing, testing, testing. And let me check my settings here. Sorry, this will just take a second. iMac microphone. So tell me if the iMac microphone is better than my stupid little okay. Now Siri's popping up wanting to talk to me. Go away, Siri. Okay. Sorry. It's always something, isn't it? When you're trying to be the doctor and the IT guy, it's tough. Let me know if you can't hear me again, but hopefully you can hear me now, guys. Okay. So if you look at the picture there, the MRI on the left, there's a broken bone in the middle of the back. The left side is the front of the person's body. The right side is the back of the person's body, and they're thrown forward. They're in a kyphosis. They're thrown forward like this from that thoracic compression fracture. If you look at the x-ray on the right, which is an x-ray, not an MRI, you can just see that there's decreased height. The vertebral body is compressed as compared to the other side, compared to the bones that are above and below. All right. Took a drink there. Okay, let's get back to this. That's just an imaging study showing it. This is a bone scan for people who can't have an MRI and we're still concerned that they have, or we think they have fractures all the way up and down their back, or we think they have maybe cancer and they have pathological fractures. Then we can do a bone scan to show where their broken bone is. And on the right side, there is a CT scan, which can show that focuses more on bone than soft tissue. Again, MRI is probably the best study to use. So again, this talk here that I'm using, guys, is really more for doctors, but that's okay. There's no reason why I can't show this to you guys. That's the pedicle, and right there where they have that metal ring, that is the bony structure that we're trying to pass the needle through to get the balloon into the bone. So when we're looking at it from one angle, that all the way to the right, that number 2, that's like you're taking a pipe and you're looking at it on end, and so the x-ray creates that little circle. You can actually see one on both sides. Owl's eyes, it's like a little man with 2 eyes and a nose in the middle where the 5 is. That's the posterior spinous process. Here, and that's where we're looking at basically through the patient's body front to back. We're looking on the one in the middle, we're looking from above, and again, you can see where that wire is, showing where the pedicle is. We're trying to pass that needle right there at the number 2 through that little wire, and then from the side all the way to the left, you can see from the side. So it's a pretty small target. You have to really know what you're doing, because if you miss and you go into that, in the middle picture, you see that sort of hole in the middle? Well, that's where the spinal cord is. And if you miss that little bony track and go into the spinal cord, you paralyze the patient. That is a party foul. So here, not only do we want to stay out of the canal where the red circle is, but we want to stay out of the red triangles up front, because that's where big vessels like the aorta live, and stabbing someone in the aorta with a sharp needle generally doesn't have a good result. Here, sorry for the sarcasm. Here, now this is more like a regular x-ray, not just a single bone. Again, you can see on that top left picture those owl's eyes. You can see the pedicles that we're passing through. That's looking from above. And then, of course, the one that's top to the right is where we're going to pass the needle. And you guys just kind of get a basic idea of what you're looking at here, because I'm going to actually show you a procedure that I did in my office, and this will help you kind of understand that, but you'll get another chance to see it again. This is the technique. There's no reason to even talk about this. But again, if I was teaching a doctor how to do this procedure, these are some of the things that I would go over with them. We're going to square off the end plates. We're going to put our needle in the owl's eye. We're going to shove our needle through the owl's eye. We're going to be looking at that on AP and lateral. Again, these are things that you don't need to worry about. We drill a hole, because you can't just push the balloon through that bone in most cases. And so that's a drill going through the working portal called the cannula, or the Jamshidi cannula. And that drill and you're going to see that when I show you my procedure. Once you remove the drill, now you put an inflatable balloon. The portion of the balloon that inflates is between the 2 dots. That's how you know where it is. Those radio opaque markers that show me where the balloon is, so I can put it in the right spot. You want to get it middle or anterior third of the vertebral body. And then you want to blow those balloons up. This is like a really ideal case. Honestly, in reality, the balloons blow up where the bone is soft, okay? Because it's basically a pressure thing. It's gonna asymmetrically inflate in the direction of least resistance. So where there's really truly, and that works out, because where the bone's really broken, that's where the balloon kind of goes, and where the bone's not so broken, it doesn't go in that direction. And I'll show you with my case, which is a little bit more of a realistic case. This is more of a textbook. Someone got out of their 1,000 cases, this is one of their ones that's very textbook. That's the balloon inside the bone. Now they're injecting the cement, and there's the cement filling the bone. The cement hardens within minutes, rendering the bone essentially fixed and hard as a rock. And that's it. Those are my slides there. Okay, all right, so does anyone have any questions? Let's see, I hadn't looked. That's better, yes, no problem hearing you, it's fine, turning up the mic worked, okay, I don't know. Okay, all right, so there's no questions. Guys, if you have a question, feel free to throw that out at me now. Otherwise, I am going to go to my video. So I've got a couple of views here for the video. There's the video itself, and then I've got one where I'll actually be able to hop on, because I got this green screen, I got to use it, and I can, you know, sort of point to things, right? I remember it's backwards, mirror, mirror. Anyway, all right, very cute. Okay, so here we go. So here's a short video. I condensed this down. Here we go. The line there. There's just midlines about there. See how that looks. Okay, guys, so what I'm doing here is I am just basically drawing a line in line with the top of the vertebral body. I'm making skin markings to kind of show me where the bones are, because obviously I can't see the bones. I'm doing this using an X-ray camera. So I'm just sort of getting some surface markings to help me know where to make my poke hole incision. Good. Go in there. Okay. Now, so I'm just getting a nice field block there. Might as well do the other side while I'm here. Okay, so all I'm doing here is I'm injecting some local anesthetic. Although the patient has that medication, sleeping medicine, they're awake but comfortable. They really probably won't remember anything, but I can actually communicate with them, because if I'm stabbing them in the spinal cord, it's good to know that. They would actually be able to communicate with me. They'd feel pain. Luckily, in 2,000 levels, that's never happened to me. But having the patient be able to communicate with you is actually key. Having the patient completely under is where a lot of bad things have happened to people. Okay, should just be pressure. I don't know what the true angle is going to end up being, but I'm about to find out. Okay, let's see. Okay, let's go and get a lateral and see what. So here, guys, you can see there's my little owl's eye. There's that pedicle that I was talking about. See that circle right there? There's one, and then there's the other one right over there. That little, I'm getting outside the field of my little deal, but there's my other little owl's eye right there. And then here is my posterior spinous process. There's the nose of the owl. So we've got eye, and it's kind of backwards, it's weird, eye. And that's where I'm trying to pass my needle down. I don't want to go to the very inside of the tube because the spinal canal is in there. So I'm going to pass my needle just to the inside of the tube and make sure that I've entered the posterior aspect of the vertebral body before I go medial, okay? It's not that important, but for people who really like the technical stuff, there you go. Where that puts us? Perfect. Okay, that's actually not bad, but I think I'll probably just come a bit down to here. Oh, okay. So here we go, you guys. You can see my needle is right there. It's kind of hard to see. It's real light, but I'm trying to get it lined up on the side here. That's the pedicle right here. That's the top. That's the top of it. It's a tube of bone. On end, it looks like a circle, but here it looks like a tube, and I'm using that tube, that tiny little tube that you saw on that other, to get into the vertebral body. I don't want to be down here. I'll hit a nerve root there. I don't want to be up here. I'll hit a nerve root there. I want to stay right inside that tube. Okay? And that looks good right there. And that angle seems to put me right down the pedicle. So when you come back, we're going to match that angle right there. Okay. All right, here we go. Okay, so you got the angle matched for me, good. Match this angle right here. So what's the smallest pedicle? Who has this? Okay, so here, guys, again, this is what I'm talking about. Let me pop myself up there. I want to stay. If there's a circle here, okay, I know it's really weird. There's a circle here. I want to stay away from the inside of the circle. I want to stay out here until I'm actually in the vertebral body, and you'll see that on the lateral. And sometimes, a lot of times, the bone's so soft I don't have to use a mallet. But a lot of, in some cases, if the bone's a little harder, I'll use a mallet because it allows me to very carefully and in a controlled fashion advance the needle. And that needle, again, is less than 2 millimeters, or right at 2 millimeters. It's a hole so small that we just put a Band-Aid over it and some skin glue. Smallest pedicle in the lumbar spine. L1, 2, 3, 4, 5.
L1.
L1, that's right. That's right. My boys know their stuff. There. Okay, so let's go back. Actually, that was too quick. Hang on. Oh, there we go.
Right there.
Hang on. Okay, so here we go, guys. So there, once I have gotten myself to the back wall, I'm now the spinal canal's from here to about here. So once I'm inside that circle and to the back wall of the vertebral body, I know that I now cannot stab the spinal cord, which is a pretty darn big deal. It's the biggest deal in this whole procedure, is not to paralyze the patient, obviously. And so when I'm at the back wall, but not past the medial part of that circle, just if you think about it in 2D, I'm in the safe zone, and now I can press forward and go on into the vertebral body.
I think we're good right there. I think I can pull this number. Good. Okay.
All right. Let's go and get our other one in. Go back to the AP, please. Okay, here we go.
Okay, that looks good. We'll get him numbed up. Okay.
And he's doing fantastic for sure.
Talk about a trooper. Okay.
And you guys can see, that the patient is not moving much. Sorry, someone's texting me and he's telling me that he was having maybe some problems with his phone. That's why he couldn't hear me. If anyone else can't hear me, or if you can hear me, will you send me a little message here in the Facebook Live feed? If your video's freezing, or you're not able to see or you're unable to hear me, please let me know. And if you can hear me fine, and if you can see fine, that would also be good information, because there's a certain person that keeps texting me to tell me these things, and I guess he's just concerned that maybe nobody can hear me that well. Anyway, so the reason the patient is not in a lot of pain while I'm doing this is because I am become very experienced at numbing these people up using that local anesthetic. I didn't talk much about that, but I know exactly where to put the local anesthetic. It's along a whole 5-inch track or so, and so you really have to know how to do that well. Otherwise, you probably do have to take these people to the operating room to do these procedures.
Okay,
let's go and get a lateral.
That looks really good.
So now I've got both needles back here. You can see that both needles are laying right on top of each other because I'm in that lateral view. I'm in the vertebral body. I'm away from the spinal canal, which is very important. And now I can start doing my work in terms of drilling, putting balloons in, blowing the balloons up, and injecting cement. Oops, sorry.
Good. Looks good. He's doing great.
That was the drill going into the bone.
Pressure going there.
That's the balloon in the bone right there. You can see those two little markers there that show you that the balloon is in the bone. And now I'm blowing the balloon up with a liquid that shows up on x-ray called contrast. And I'm creating a space to put my cement in.
Good.
And you can see I deflated the balloon. I put the drill in on the other side. I did kind of skip those. I was trying to shorten the video a little bit. Putting the drill in on the other side. These cannulas are right on top of each other. That's what looks like one, but it's really two. And now I'm going to drill a second hole, put a balloon on the other side, blow that balloon up, and then proceed with sticking cement inside the vertebral body.
Okay.
Yeah, we will. We will. Let me get them just a little bit. This one's already been insufflated, so let me just get it back up again. There we go. Okay, let me get this. That's good. One's there. That looks pretty deep. And so here was I was talking about. That one balloon looks like it's actually higher than the other. That's because the fracture went more across the superior end plate, and the balloons find the path of least resistance. And although it looks like this balloon is kind of outside the box, it's really not. It's just the angle. When we go back to the lateral here, you'll see the balloon is well within the vertebral body, and then of course the opposing balloon is sort of more dead center, but on the opposing side. Is it better? Okay, let's go back to the lateral. And like I said, we can see here on the lateral that our balloons are well within the vertebral body, the end plate there and the end plate there, moving to the front, and then of course moving to the back of the vertebral body.
And we will go ahead and start putting cement on one side. And that's good to go. Okay, I'm gonna go ahead and just get this going first. Cement in there.
And so what you're seeing there is cement actually coming out the tip of the cannula, and it's going again to the path of least resistance. It's going to the superior part of the end plate. That's where the fracture is. So it's going more across the top of the vertebral body where the patient's break is. And you can see if you look at this vertebral body above, how tall it is and how this one's a little bit flatter. Although we might have gotten a little bit of correction in his bone, the primary goal here is to keep him from compressing any further and ultimately keeping bone from shooting backwards into the spinal canal and paralyzing the patient.
Okay, let that kind of do its thing for a sec. This power just come a little closer again. There we go. We're just getting the cement in there now, buddy. You're doing great. That looks good.
On the bottom side of it now.
That one's actually more centered. Okay, you're doing great. Okay, let's get an AP in to see what we got. Okay, good. Yeah, the top one's crossing. And that looks great. And that's where the fracture was. It was across.
And so this is what I'm talking about. This is where the fracture is. And so the cement goes to the path of least resistance. Obviously, it's going to go where these balloons were put in and inserted because they created a little bit of space for the cement to go. But any area where the balloon wasn't, the cement's going to flow into the path of least resistance where the softest bone is. And obviously, I didn't put the balloons across the top of the bone, and that cement's flowing into that area, making this a superior, more of a superior end plate fracture on this particular vertebral compression fracture. You also notice there's a little bit of blood. We probably lost about a teaspoon of blood. It looks like a lot more than it is. Usually, I have these where I hardly see a drop of blood, but this patient, I believe, was on, turns out was on fish oil, and that's why he was bleeding more than I would normally expect. But it's no big deal. Literally, the total blood loss is like a teaspoon, and he stopped bleeding when we were done.
Stop. So it looks like me undo the pressure because we're losing some of that. Okay. Yeah, we're doing good. No, we crossed there very nicely. I think that side's probably good because it's up and down. I think if anything, I might put a little bit more on this side. So go ahead and go back to the lateral. A good placement of the cement. Very, very happy with the placement. So everything went really well. And I'm going to go ahead.
So we got a great fill here. Excellent fill, top to bottom. The cement went to the very back edge of the bone, and we don't want it to squirt out into the canal here. That would be really bad. But I can see by the shadow of it that it's conforming to the inside of the bone very nicely. But most of the cement you want in the anterior 2/3 of the vertebral body, kind of where it is, up here in the front. And you just want to stay away from the back. If you could get in the back safely, that's fine, but you're just a little bit more risk. That's when people get a little bit carried away and they end up with cement in the canal, and then they have to call someone like me, a surgeon, to clean up their mess.
Just pull back a little bit here. See if I want to. So when you're bipedicular, you have to look at both pigtails. Here we go. So we're looking at one, and
so what I'm doing here, guys, is, let me go back just a little bit here, just a little bit. What I'm doing here is I'm pulling the jam sheeting needles out very carefully, because if the cement hasn't cured yet, if it hadn't become hard, it can actually follow these back because it's a liquid under pressure. It'll basically come out, and some people have had cases, luckily it's never happened to me because I'm always careful about it, where the liquidy cement will come out through the holes and even up to the surface of the skin, and then the patient has to have an operation to have that cement dug out of their back. It's not the end of the world, but it's annoying, and it's something terrible that you don't want to have to explain to your patient. And again, it's really easy to avoid. I've done a couple thousand levels, and it's never happened to me once. So good to just, you just got to be, you just always have to treat. Now, I'm assuming that we're still rolling here. I don't know. I don't know if everything's messed up or not. Okay, so it did look like my Facebook feed there. I see the delay. It's very distracting when you see the delay off on the other screen. Anyway, I hope you guys enjoyed this. This is one type of fracture. It's a very specific type of fracture. It's the kind that's going to affect grandma and grandpa. It's the kind that's going to oftentimes get missed or get a delay in diagnosis. So if grandma said, grandma may say she has a little bit of pain in her back her whole life, or grandpa. But if all of a sudden the pain becomes really severe very quickly, from a relatively, people think, well, grandma, you just sneezed. I mean, come on, what could you have done to your back from sneezing? It very well could be a vertebral compression fracture, and it may be treatable in a brace. I treat lots of them in a brace, but some people will get treated with this procedure, minimally invasive, done in the office, 2 millimeter incision, walk in and walk out, no general anesthesia. This is what most people prefer to have done because it's such a successful, tried and true procedure, and people are usually so very happy with it. So if anyone has any other further questions, let me know. You can post them to this feed, and I'll be happy to answer them, and I can even do another Facebook Live or something if I need to go over that information, or I'll just post the answer or post a link to the answer to your question. I hope you guys enjoyed this. Don't forget to go to Spine Center of Texas Facebook page and sign up for my mailing list. And yes, I owe somebody a free t-shirt. I forgot to do it last week. I ended up going out of town. So I got a couple of free t-shirts coming. I promise. We give people t-shirts. We give our patients free t-shirts all the time. So it's not like we don't have the t-shirts. I just forgot to do the free t-shirt thing. I'll do it real soon. Again, this was on vertebral compression fractures. Hope you like my new little green screen addition to tonight's Facebook Live. I hope you found this educational. If there's anything you can think of to make this better, to help you understand better, did I go into too much detail? Did I not go into enough detail? I have a hard time believing that, but if you think so, then let me know. I'll cover whatever you want. There is a lot more detail to these things than I'm giving you, but I tend to, I'm treating you almost as if you're a physician here, and you can take from it what you like. I try to keep it simple, but also add some of the cool technical aspects of these procedures. So, you guys have a great night, and until our next Facebook Live. And, oh yeah,